Good afternoon. From the Department of Gynaecology, presenting our this time on important market management. Today we have a presentation happy regard towards the exception optimized behavior all of it too easy. You have women coming 18 pregnancy with multiple problems. Nowadays, which you present. Dr. Jyoti will interview and listen to you.
So, good afternoon. So today we are presenting a case, a unique case. We know that India is the diabetic capital of the world, and over a decade we have seen that the prevalence of diabetes in India is on an increase. In India, the prevalence of gestational diabetes is approximately 13%, but the pre-existing diabetes, they affect a very small proportion of the pregnancy. But these women with pre-existing diabetes, they require an intensive clinical care and support before and during the pregnancy to optimize glycemic control. Although we have a good glycemic control during pregnancy, which reduces the risk of major perinatal complications, still there is an increased risk of adverse pregnancy outcome, which can be either adverse fetal outcome, like baby can have congenital malformation, increased risk of perinatal mortality and prematurity, or there can be adverse maternal outcomes, like there is increased risk of these patients going into preeclampsia, preterm labor, or there is increased need of cesarean delivery or the worsening of diabetic complications. So these risks underscore the importance of a preconception counseling, close monitoring, and stringent blood sugar control for pregnant women with pre-existing diabetes. Without proper medical supervision and glycemic control, the risk to both mother and fetus increases significantly. So here we are presenting today a unique case of type 1 diabetes marked by a complex interplay of long-standing insulin dependency and the physiological demands of the pregnancy. This case will highlight the heightened maternal and the fetal risks and the challenges, which need to have a highly individualized and multidisciplinary approach to ensure an optimal outcome. So to present the case, I will invite Dr. Sakshi, who is junior resident in our department, followed by discussion by our senior resident, Dr.
Thank you, ma'am. Good afternoon, everyone, respected teachers and my dear colleagues. Today I'm going to present the case of Mrs. S. Mrs. S, who is 23 years old, housewife, resident of Delhi, known case of type 1 diabetes since 7 years of age. She's a primary gravida and her brother is also known case of type 1 diabetes. Let's go over the patient's pregnancy journey. So patient visited gynecology OPD for the first time at 31 weeks. Her home blood sugar records were fluctuating, ranging between 40 to 350 milligram per deciliter, and she was advised admission under endocrinology department. Her first trimester course, she had a spontaneous conception. She was on insulin glargine 10 units for type 1 diabetes, and she had no ANC visits or no sugar monitoring done at home. Basically, it was an unsupervised pregnancy. She had one episode of hypoglycemia at 12 weeks, for which no medical help was sought and managed symptomatically at home. Her second trimester, she was non-compliant with the diabetic diet. No blood sugar monitoring was done. Her anomaly scan was normal, and her blood thyroid profile was deranged, and she was started on tablet of 50 microgram once a day from a local physician at ASH level of 7. She has history of high-grade fever with rhinitis and cough with mucus expectoration at 5 months gestation, followed by progressive shortness of breath, for which she visited private hospital after 2 weeks of onset of symptoms. At admission, her vitals are this. Patient was evaluated and diagnosed with viral pneumonia with sepsis, and she was referred to a high. She presented to AIIMS emergency in hypoxemic respiratory failure at 27 weeks of gestation. Patient was conscious and oriented, and her vitals are as follows. Her saturation was 86% on room air, and she had to be put on HFNC. On chest examination, bilateral fine plates were present, and her abdomen was relaxed, and vital ulcer was present. Patient was started on broad spectrum antibiotics, bronchodilators, steroids, and blood sugar monitoring was done, and insulin was started according to slide and scheme. Patient was intubated in view of worsening respiratory failure. The basic investigations were done, which were normal, as you can see, but an influenza B came out to be positive. So our diagnosis was influenza-induced ARDS. At time of intubation, blood pressure records were raised and within the range of 180 to 190 by 98 mmHg, and for which injection lobetalol was given, followed by BP record of 150 by 86, and urine albumin was +1. Her blood pressure records were monitored and were continuously in the range more than 150, for which hypertensive workup was done and tab lobetalol 100 mg twice a day was started. Her hypertensive workup, her urinary ACR was raised. Her fundus was suggestive of severe non-proliferative diabetic retinopathy in left eye and proliferative diabetic retinopathy in right eye, and for which she was planned for photo-lethal population. On ultrasound, which was suggestive of stage 1 fetal growth restriction, for which bi-weekly fetal Doppler monitoring was advised. Her other basic investigations, and we were in dilemma whether these changes are due to preeclampsia or these are due to diabetic retinopathy. These are the ultrasound findings. Patient was discharged approximately after 1 week on blood sugar and blood pressure monitoring, on the levodopa, on injection latest and injection regular insulin, and was advised bi-weekly Dopplers and was advised to follow up in gynecology OPD, but patient was lost to follow up and visited hospital in third trimester. Patient got admitted in view of deranged blood sugar records in view of deranged blood sugar monitoring done at home, which is as follows. Her blood pressure, blood sugar record was very erratic, ranging between 40 to 350 milligram per deciliter. Patient got admitted, her diabetic diary was reviewed, 2-hour blood sugar charting, followed by charting, because there were many hypoglycemia episodes, and she was kept on insulin infusion. These are the blood sugar records at time of admission. Blood pressure charting was also done during the hospital course. Blood pressure was more than 140 by 90 and 90 hypertensive have to be titrated. And tab different 10 mg twice a day has to be added along with tab levodopa 200 mg twice a day. Her hypertensive workup was again repeated. Urine ACR was raised, 24-hour urine protein was raised, and ECG was normal. This is a basic investigation profile. HbA1c was 7.9. For diabetic retinopathy, as already told, she underwent the photo-laser population in both eyes 1 week apart. For fetal monitoring, fetal Dopplers were suggestive of absent end diastolic flow, for which daily fetal monitoring has to be done, and steroid coverage was done for fetal unmajority at 31 weeks. At 32 weeks, on routine fetal surveillance, we noted the recurrent spontaneous dissolution up to 80 weeks of commitment on non-stress test, for which decision for emergency cesarean section was taken, and she delivered a female baby weighing 1050 grams. Apgar score was 7 by 8 and baby was small for gestational age. No gross congenital anomaly was there, but baby developed late onset sepsis. So I'd like to hand over the stage to Dr.
Good afternoon, everyone, and respected teachers and dear colleagues. So we have seen the case and the complications and the challenges in this case we have faced. As the patient never been evaluated for type 1 diabetes and associated complications, and there was no preconceptional counseling taken, and the baseline investigations were not available with us. So we faced a dilemma whether the comorbidities or complications patient is having is pregnancy induced or previously existing comorbidities, which raises multiple maternal and fetal concerns. And that's why such patients need multidisciplinary team approach for better management, which includes obstetricians, fetal medicine, endocrinologist, nephrologist, neonatologist, ophthalmologist, nutritionist, and anesthetist. As in our case, the patient require cesarean section for the delivery. And the preconception care can improve the glucose levels in early pregnancy and in turn reduce the risk of adverse pregnancy outcomes. And the key components includes patient education, management of the hyperglycemia, proficient diabetes self-care, and medical optimization of pre-existing complications and comorbidities, and vaccination before conception. After pre-pregnancy care, patient require multi-targeted management of type 1 diabetes in pregnancy, which includes lifestyle changes, appropriate carbohydrate counting, regular physical activity, avoiding excessive weight gain, and folic acid supplementation, And the pharmacological intervention includes early and intensive hypertensive therapy, prophylactic low-dose aspirin, and if patient is on ACE inhibitors preconception, that has to be stopped during pregnancy. Effective clinical and psychosocial support, diabetic monitoring by continuous glucose monitoring, and use of insulin pumps, and management of the diabetes-related complications like hypoglycemia, ketoacidosis, and screening for retinopathy and nephropathy. During first trimesters, we have maternal concerns like management of the glucose levels and to maintain the target levels of fasting between 70 to 95 or 2 hours between 100 to 120, because there is a higher risk of hypoglycemia during first trimester because there is increased insulin sensitivity. Also, there is an decreased intake due to nausea and vomiting. In second and third trimester, there is increase in insulin requirements after 18 weeks because of the hormonal changes, and risk of preeclampsia is more during this time. So we need to monitor the patient BP and patient with the pre-existing diabetes. During third trimester also, there is a frequent acceleration of insulin doses as insulin requirement plateau by 37 weeks. And also there is an increased risk of preeclampsia or asymptomatic bacteria that has to be looked into. During pregnancy, we should evaluate the patient for their BMI, assessment for the kidney function, and eye examination, assessment for the vascular diseases, neuropathies, and gastroparesis. HbA1c should be seen, blood pressure, thyroid profile, and urine culture. HbA1c is important because as there is increase uncontrolled sugars and increase in HbA1c, that will increases the risk of congenital anomalies with subsequent increase in HbA1c. That's why here fetal screening plays a pivotal role, because screening for aneuploidies, neural tube defects, and other congenital anomalies like congenital heart disease is important. We also offer fetal anomaly scan and fetal echo at 18 to 20 weeks of gestation for better fetal screening. And during pregnancy, we should monitor the fetus type 1 diabetes without any complication. Then should be started at 28 weeks and repeated after 4 weeks. And after 32 weeks, it can be done twice weekly. But if the type 1 diabetes with pregnancy is complicated with FGR, oligohydramnios, or preeclampsia, so we should start the screening as early as 26 weeks of period of gestation. During intrapartum management, the most important is to manage the glucose level, and we should maintain the target range between 70 to 125. And we also need to maintain the hydration of the patient to prevent the risk of dehydration and ketoacidosis. During postpartum also, we need to vigorously monitor the glucose levels as there is an increased risk of hypoglycemia, especially while breastfeeding, as insulin sensitivity increases. In contraception, we suggest long-acting reversible devices are contraceptions are preferred. Rest are also be considered. So in review of literature, we have seen this Valentina et al. They did a retrospective study including 135 patients with pre-gestational diabetes, including 73 with type 1 and 62 with type 2 DM. And the outcomes were that the risk of pre-gestational diabetic retinopathy, hypoglycemic events in first trimester, higher birth percentiles are seen in type 1 diabetes in pregnancy. Another study by Julian et al., where they have, it's a retrospective study, they've seen the progression of the diabetic retinopathy and predictors. So they have found out that there were 499 pregnancies, which included 375 patients, and there were progression of diabetic retinopathy during the pregnancy is 21%, newly developed but 24%, and worsening was seen in 15.9% of cases. The conclusion of this study was that if there is a poor glycemic control, the risk of progression to diabetic retinopathy would be high, and HbA1c would be a good predictor. Pre-pregnancy HbA1c would be a good predictor to assess the diabetic retinopathy progression. They also suggest the retinopathy during pregnancy exacerbate and can occur with rapid reduction of glucose levels. Improvement in management of hyperglycemia should be gradual over months prior to pregnancy if possible. And this also suggests retinal assessment during pregnancy at the first visit of antenatal and then 28 weeks of pregnancy. If diabetic retinopathy is already present, then additional retinal assessment can be advised at 16 to 20 weeks of gestation. And if non-proliferative diabetic retinopathy, then should be examined every monthly. And for proliferative types, we suggest photolaser coagulation. And the study by Sarah et al. It's a diabetic kidney disease and pregnancy outcomes. It's they reviewed 68 papers over a period of 20 years, and they found that most of the women were young, nulliparous, and had a long duration of type 1 diabetes. They had a high rate of maternal and fetal complications like preeclampsia, stage 1 fetal growth restrictions, and high rate of cesarean section. With this, they concluded that with improved diagnosis and management, the rate of complication has come down. The management of diabetic disease in pregnancy, we should, as pre-pregnancy, we should assess the basic renal function. If everything is normal range, and if not normal, then we have to refer to the nephrologist. Preconception counseling should be done, and if patient on ACE inhibitors should be continued, and high dose of folic acid should be advised for 3 months prior to a conception. During pregnancy, regular multidisciplinary team visits should be made every 1 to 2 weeks. Low dose aspirin should be started before 16 weeks of gestation. And if there is a proteinuria in nephrotic range, we should advise a low molecular weight heparin during pregnancy and postpartum period. And we should maintain a target blood pressure level, systolic between 110 to 130 and diastolic between 70 to 90. And should monitor the creatinine, ACR, and PCR level every 4 weekly before 32 weeks and every 15 days after 32 weeks of period of gestation. In postpartum period, if patient was already on ACE inhibitors before pregnancy, should be restarted. We prefer enalapril and captopril during breastfeeding and ensure follow-up to the nephrologist. Diabetic neuropathy is another complication which is seen most commonly in type 1 diabetes. Peripheral and autonomic neuropathy are there. Peripheral is most common neurologic complication associated with injury and infection. Autonomic, there's a decreased cardiac responsiveness and orthostatic hypotension. And patient with diabetic gastroparesis, they will precipitate extreme hypo and hyperglycemia, ketoacidosis, and frequent hospitalization, and may need parenteral nutrition. Now I would like to call upon the neonatology team to give their opinion.
Till they are loading the slides, may I request Dr. for their further.
So in type 1 diabetes, so endocrine is actually get pregnant. So from endocrine point of view, there are 4 or 5 videos where we do effort to improve the pregnancy outcomes. So as per the general clinical practice, the clinical action counseling actually starts now. We have a counselor available in the endocrinology clinic. So the reproductive issue, so preconception counseling, the importance of that pregnancy basically starts really at grades. Complications like long-term glycemic control is very important. It's very difficult to manage complications during this period. And third point is overall protein, there is a genetic despite the patient being under despite years, even when they are patient are already in the last 15, 20 years. But you see a patient come with a C1C of 9 or 10. It's not extremely general able to manage properly. It only is now challenges. The great challenges psychosocial. So the patient came to the follow-up because he visited something called hospital. The psychosocial support from our side, from endocrinology, what patient perceives, why they are not coming back, despite knowing that pregnancy is very vital. They are being lost to follow-up, I think that will be the next step. And second is the digital divide. Because initially we used to offer bonds which were like 1 to 1.5 lakhs. But we used to take on that. It's arranged for the vials. Now as the bonds are mostly 6 to 7 lakhs, we are able to offer patients the is possible. At certain stages where there is a variability in pricing control bonds and increasing digital increasing cost of this technology. The EMP offer is going down. Right? So suppose it's so they are all basically all part is taken by the NHS in EU. So insulin for CJ devices, insulin and so company has actually related cost of 1.5 to 5. Now the transactions are like 8 lakhs or 7 lakhs. Analogs when they take the cheaper one out from the market, the expensive ones. So as the cost status is increasing, so patients are where only the leads are in the basic was 2015 we had 4 or 5 instances also one is 1.5. Now
Yeah, this week because that is becoming so common with during COVID time because either COVID or that. Really, I mean, India, we had that. In India, basically, I mean, the concept of like in India, you have to really because if we are in there, we are getting so common. So we heard from
for example, the technology post that this you know person can what factors we can fix is like why the patient also. I think it is better to take a have this even what makes patient but they're not a regular follow-up, they're not able to social issues also. These are the ladies which are like, from a very poor background and married due to this circumstances. So even poor families.
Yes, we suddenly we have like when we come in the just like 4 or 5 can be one more resident. You see, that totally red one for new patient. So I just work at the 400%. We can even know that another patient category. So we always suspect
Good afternoon, everyone. So I'll be presenting the neonatal part of the maternal diabetes. So coming to the pathophysiology, so if a hyperglycemia which happens before the 20 weeks of the gestation, it leads to the hyperglycemia in the neonates, which can lead to the multiple congenital malformations, including predominantly cardiac and CNS. But if it happens after 20 weeks, after more than 20 weeks of gestation, so that will predominantly lead to the hyperinsulinemia, and then that will lead to the macrosomic baby. But coming to the neonatal, in the immediate neonatal period, these babies at a high risk of hypoglycemia, respiratory distress syndrome, and the TTNB, because the insulin, which is higher in the mother, it can inhibit the cortisol maturation effect, and then these babies are at a high risk of polycythemia. So that is particularly leading to the renal vein thrombosis in an infant with a diabetic mother. So, but we think that most of the babies in the born to the mother with diabetes and hypo are the LGA babies, but it is not true in the mothers who diabetes with the microvascular diseases. So, a term which is known as the placental vasculopathy, which has the lesser villus surface area and the vascular lesion that will lead to the impaired placental circulation. So that can also lead to the like LG babies. So in a like, study, so that has shown there is 17-fold increase odds of the SGA in babies who are born to a mother with microvascular diseases. So not in the neonatal period, even in the childhood and the adulthood, these babies are at a higher risk of the cardiovascular diseases like obesity, metabolic syndrome, and the diabetes. So both like it is pre-gestation or gestation diabetes, both increases the risk of the diabetes in the offspring. It is predominantly hypothesized to be secondary to the hypoglycemia, intrauterine hypoglycemia that will lead to the metabolic programming. So we can see the offspring is at a high risk of around 5 to 10 times of having diabetes. So current status of the baby, as we can see, the baby was born at 31 week at the weight of the 1 kg. So in contrast to the LG, baby was SGA, and currently day 10 of life required had a respiratory distress syndrome. Currently on non-invasive respiratory mode of support with the parental nutrition and feed only. Currently like 100% mother's milk and had late onset sepsis in view of long life in situ. So diabetes per se not increase the risk of the sepsis in the baby. Thank you.
Thank you, doctor. Now I would like to call upon anesthesiology team to discuss their challenges they face.
Good afternoon, everyone. The anesthesia team for this case include Dr. Support faculty, myself, Dr. Ashwin, and Dr. Ashwin. So this patient, we got a call for this patient for emergency cesarean section, category 2 emergency cesarean section. When we did the pre-anesthetic checkup, so it is a 23-year-old female patient, 31 weeks period of gestation, with type 1 diabetes, long-standing type 1 diabetes, with uncontrolled sugars, with endocrine damage, diabetic retinopathy and nephropathy, hypothyroidism in pregnancy, which was controlled, preeclampsia with controlled blood pressures, and with a history of influenza 1 month back, with a history of mechanical ventilation of 3 days. Investigation, the baseline investigations of the blood count, the coagulation profile, the renal and the liver function tests were within normal range. With regard to the blood glucose, they were over the roof. It was mostly in range of 220 to 280. But urine sugars and ketones were within normal levels, and serum electrolytes were also within normal levels, and the TSH were within normal. So, from anesthesia perspective, the main concerns were uncontrolled type 1 diabetes, which required insulin infusion and rigorous RDS and potassium monitoring, with a high risk of diabetic ketoacidosis in the intraoperative period because of the surgical stress. The endocrine damage, diabetic nephropathy, which can lead to periodic worsening of kidney function. The past history of influenza and mechanical ventilation. So we try to avoid GE as much as possible. And hemodynamic control due to the history of the So our anesthesia plan was combined spinal epidural. Intraoperatively we had taken the patient inside the operation with standard monitors attached, and combined as per the plan, combined spinal epidural was given. Intraoperatively, the blood sugars were 241, and when we received the patient was already on insulin infusion of 2.5 units per hour. Since the blood sugars were high, we have increased the insulin. The intraoperatively, total IV fluids given was 900 ml, taking into consideration of the blood loss. Urine output was adequate for the duration of the surgery. Post-operative concerns mainly were to monitor for diabetic ketoacidosis, preeclampsia, and potassium monitoring since the patient was on insulin infusion. So overall, from anesthesia perspective, preoperatively, we would like to assess for in the preoperative period. We would like to assess for the control, the sugar, the RDS control, and assessment for any complications associated with the uncontrolled diabetes, be it any organ related or like be it MI, be it cardiovascular, cerebrovascular, or any neuropathy associated. From anesthesia perspective, again, the difficult therapy associated. Intraoperatively, the anesthesia management is individualized. In this case, since patient had a past history of influenza, and the regional anesthesia obviously has its own advantages in for cesarean section, and diabetes is associated with difficult therapy. We move forward with regional anesthesia here. And post-operatively, we have to do rigorous monitoring to ensure that patient does not land up in any acute complications like diabetic ketoacidosis.
Now I would like to call the Parliament to summarize the case.
So the type 1 diabetes affects a small percentage of pregnancies each year, but poses great risk to the pregnant mother and the developing fetuses. Preconception planning is very important to avoid the unintended pregnancies and to minimize the risk of the congenital defect in the baby. HbA1c goal at conception is less than 6.5%, and during the pregnancy it is less than 6%. It is also critical to screen for and optimize the comorbid illnesses such as retinopathy and nephropathy. Blood pressure goals must be considered carefully, as lower treatment threshold may be required for the women with nephropathy. During pregnancy, continuous glucose monitoring use can improve glycemic control and neonatal outcome for the women with type 1 diabetes. The rates of severe hypoglycemia are increased during pregnancy. The low dose aspirin is recommended soon after 12 weeks of gestation to minimize the risk of preeclampsia, and the importance of discussing long-acting reversible contraception before and after pregnancy cannot be overstated to allow for appropriate preconception planning. Thank you. Now I would like to invite expert comment.
I think it is very important to convey the message to the other specialties, whether it be endocrinology or the cardiac or the medicine people, that it is very important to send patients for preconceptional counseling, because optimizing the health before they become pregnant is more important than facing these kind of dilemmas that we did. And so I think that's another, everything is more or less covered, and I think it was a good management. So thank Dr. Reshti for taking her in and monitoring her to be delivered her, and other people also really helped to take care of this. Thank you. Looking after the baby, very important now.
Baby will survive.
Yes. So, this came up.
At least we have to get into lecture. This daughter, he said he got on the night, and offered me the allow for HIV rather than how to really get that. He said any day now, much more than he is one of the obvious for real parents and leader. Really, really serious. Do something for it. Not out there. He is some factory, in factory, that for leading to get to demand every year.
Thank you.
Yes, for the first time she presented to casualty. No, sir. This was not the usual case. Usually they don't present. The patient was already having respiratory problems, maybe because of influenza, because of that. But she managed herself at home. When she started developing shortness of breath, then she was referred. Yes, sir.
apparently the guy is really good. And so what we do lose control. And I think pregnancy is in terms of control. Because she has a lot of control.
Yes.
So is it similar? But this what's happening is that initial 16 weeks of pregnancy, there is a increase in insulin sensitivity, there is nausea, vomiting. So system gets disrupted. So the patient has 5 minutes of pregnancy for hypoglycemia. Then suddenly the insulin resistance starts increasing, and every week it increases by 5%. Every week there is a change in insulin requirement. The second, the child obviously then they are maybe very babies. The mom they again have a difficulty adapting with the schedule. It also and the child also cheated. So I thought that during the pregnancy was
It depends on if the patient is aware of her condition, then we can, patient also knows what all problems can have. She was monitoring her sugar. But in this particular case, important was that she was diagnosed at 7 years of age, and since then she was on Gilargine, same dose, without being monitored, without monitoring sugar, and without any change. So she was neither aware about what were the conditions. So there were, that's why the complications were more on this patient because of this.
so the patient is basically for example, the patient which is like go for education. Very poor service. The times poor family, affordability issues, and dealing with visits. Everything is number of visits. Most of these patients can grow because of these resources. And why social support is patients time on activities. Like for example, when you started with generic pharmacy and that sort, a lot of the rates are dramatically increased. Because patient comes and now easily has been started. Patient comes and aliens.
So the compliance is also very
Social support actually is very, very psychological part. Once you understand what are the difficulties, it's as much as possible. To follow up rates and compliance increases. Not to be patient. Thank you.